So, let us begin with our very first lecture for the season. And it is my pleasure to introduce James Le Fanu. He studied the humanities at Ampleforth College before switching to medicine, graduating from Cambridge University and the Royal London Hospital in 1974. He subsequently worked in the renal transplant unit, cardiology departments of the Royal Free and St. Mary's Hospital in London. For several decades now, Dr. Le Fanu has been a regular medical columnist for the Sunday and Daily Telegraph. Now, I first became acquainted with Dr. Le Fanu from our former dean of the School of Medicine, James A. Pittman, back in 2000, who handed me the first edition of Dr. Le Fanu's book. And as only Jim Pittman can do, any of you who remember Jim Pittman, this will be definitely in character. He never suggested that you read anything. He handed me the book. He says, "You're a historian. You need to read this book." And I did. And I soon realized why Dr. Pittman was so emphatic about my reading it. It contained everything Jim loved in a book. Insightful analysis served up with large doses of history and spiced up with just the kind of controversy and bold conclusions that made you, whether you agreed with them or not, pause and think. Well, I'm happy to say that Dr. Le Fanu has a new edition of that book out, and hopefully we will be having a book signing following this lecture with copies available. So I will simply say, without further ado, let's welcome James Le Fanu as he presents The Rise and Fall of Modern Medicine.
Right. Thanks very much, Mike, for those kind words.
And the invitation to the Magic City. It does seem perverse to talk of the rise and fall of modern medicine. When I was writing this book, as you can imagine, I spent a lot of time in the library at the Royal Society of Medicine in London. And my presence there, day after day, sitting in the same seat, piles of books, side by side, naturally elicited the curiosity of some of my fellow library users. And when I was, on several occasions, when I was minding my own business, doing a bit more photocopying another article, somebody would come up and say, "Well, what are you doing? What are you writing about?" And when I told them I was writing this book called The Rise and Fall of Modern Medicine, it produced a certain sense of bafflement. Because, of course, everybody knows about the rise, the supreme, one of the supreme epochs of human endeavour, the extraordinary achievements of medicine in the last 60 years, but they just didn't get the bit about the fall. But the most schematic outline of the major landmarks of the last 60 years reveals a very, very distinctive pattern, where from 1945 onwards, for the best part of 30 or 40 years, there was a firestorm of innovative drug discovery and technical innovation that peaked or plateaued in the early 80s, and creating an intellectual vacuum that was being filled by a very different view of the aims and priorities of medicine. Now, interpretation is, of course, of interest of its own kind. But as the great English writer, I have his words, G.K. Chesterton famously observed, history is a high point of advantage, from which alone men can see the age in which they are living. And from the high point of advantage, looking back over the past 60 years, this also makes sense of, in many ways, the curious problems, or not curious, which would seem to be contradicted by medicine's success. And one of which is that doctors are, for some reason, rather less satisfied with their professional careers than they used to be, as revealed by this particular slide. I hope this works. Oops. And here we have a doctor's series of cohorts being asked, do you regret your decision to become a doctor? And here we have back in 1966, and you could imagine extrapolating this back where the answer to that question is less than 10%. You can imagine extrapolating back in the 50s, where people just wouldn't have understood the question. And decade by decade, there's this sense of a sort of sense of disillusion. Now, there might be many reasons why people might not be thrilled by their, might have regrets about their chosen profession, but this, I think, provides an interesting insight into the changing tenor of medicine, and then also associated with that, the further paradox that despite the extraordinary success of medicine in making our lives so much better and so much easier in a way, people paradoxically are now much more worried about their health than they used to be. So here we have a cohort of people, which in 1968, asked whether they believed that their health was improving or deteriorating. And in 1968, the most vast majority thought they were improving, and only a small percentage thought it was getting worse. And 20, 30 years later, an enormous reversal of that interesting second half. So these things, it's possible that the changing pattern of medicine over the last 60 years might, in a sense, illuminate these important trends. So anyhow, to begin, I start with a sort of schematic outline of the major achievements of major landmarks of medicine over the last 60 years, and there's a lot of data on the following two slides, but I will, as it were, draw to your attention the major categories. So we start, of course, with the assault on the major assault on infectious diseases, and here we have penicillin in 1941. We have the cure of TB with streptomycin, the PES in 1950, childhood immunization, polio vaccination. And then there are the major therapeutic discoveries which have transformed the practice of medicine. Cortisone in 1949. What do we have here? Here is the oral contraceptive pill. There is chlorpromazine for the treatment of schizophrenia. Hormone replacement therapy, oral contraceptive pill, levodopa for Parkinson's in 1961, and so on. And then in addition to that, there is the major developments in technology and surgery, which opened up the possibilities for treating many of the chronic problems of aging. We have intraocular implant for cataracts in 1948. The operating microscope, which makes such a difference to so many different disciplines, and kidney transplantation, Chinese hip replacement, and coronary bypass. So, an extraordinary epoch of change and innovation. And then, as we go on for the next two, the subsequent 30 years, of course, there's still important things happening, but there's a very strong sense of, sort of slowing down this rate of innovation. Very important, the cure of childhood cancer, which I'll come back to in 1971, introduced production of these imaging techniques, the CAT scanner in 1973, the first test tube baby in 1978. And one which we'll talk about right at the end, is a very significant discovery of helicobacter. Now these, of course, each of these is an extraordinary story of human life, which would merit an entire hour-long lecture on its own. Which obviously, my purpose really today is, as it were, to try to draw out some of the reasons which lie behind this extraordinary, and in a sense, sort of extraordinary epoch of human achievement. And we start with the two central pillars of the therapeutic revolution, and they are the introduction of antibiotics, penicillin, for the cure of infectious disease, and cortisone, which treatment of inflammatory disorders. And we start, in 1941, Albert Alexander, an Oxford policeman, was the first person to receive penicillin. Several weeks earlier, he had been, while pruning his roses, he was scratched on the arm, and the scratch had turned septic. and he was now, as his Dr. Charles Fletcher described it, pathetically and desperately ill with his vast cavitating lesions in his lung. And I quote, "Penicillin therapy was started every 3 hours. All Mr. Alexander's urine was collected, and each morning I took it over to the pathology laboratory on my bicycle, so the excreted penicillin could be extracted to be used again. There I was always eagerly met by the members of the penicillin team. On the first day I was able to report that for the first time throughout his illness, Mr. Alexander was beginning to feel a little better. 4 days later, there was a striking improvement. On the 5th day, the supply of penicillin ran out, and Mr. Alexander's condition deteriorated, and he died a month later. Regrettable indeed, but a reminder to future generations of that crucial transition moment between human susceptibility to infectious disease and the ability, thanks to science, to cure. Now, of course, we all know that the origins of penicillin lie with the fortuitous discovery by Sir Alexander Fleming of the inhibition of bacteria by a contaminating mold of Penicillium notatum, which he, of course, famously failed to pursue, and failed to Sir Howard Florey and Sir Ernest Kane at Oxford University in the early years of the war, to transform the Oxford Department of Pathology into a penicillin factory to produce penicillin in sufficient quantities stored in the computer. Now, we now know that, of course, that penicillin was not just a lucky break, and that over the subsequent 10 years, the screening of tens of thousands of bacterial organisms identified virtually the full range of antibiotics in common use today, which will be familiar to all of us in practice: chlorphenidol, tetracyclines, cephalosporins, and mystatin, and so on. There are 3 points, I think, that need to be made about the antibiotic revolution, which within a sense we are familiar, but which need to be emphasized. The first is the comprehensiveness of the antibiotic revolution. There are, as we know, hundreds of different infectious diseases, from sore throat to tuberculosis, meningitis, but there's not a single which is not treatable by one or other. That's the first. Second, the microorganisms that produce them are incredibly simple, but the antibiotics themselves, chemically, are incredibly complex compounds, which exert their effect through a whole variety of different ways, interfering with the production of DNA, interfering with the production of whole hormones, and the proteins and enzymes, and so on. And the third concerns their role in nature. The conventional view, of course, is that antibiotics are produced by microorganisms as part of the process of chemical warfare to maximize their chances of survival. But this man, Waxman, Stanley Waxman, who discovered streptomycin as treatment for tuberculosis, after a long series of investigations, realized that this could not possibly be the case, particularly because the concentration of the antibiotics in the soil was much too small for them to have any significant primary effect. So he concluded that antibiotics were a purely fortuitous phenomenon. There is no purpose behind it. The extraordinary proposition, which I will come back to in a second, once we have considered the second pillar, which of the revolution, cortisone, prompted, as you might know, by the chance observation of a 65-year-old man with severe rheumatoid arthritis, that to his physician, Philip Hench here, that during a recent episode of jaundice, his rheumatoid arthritis had fallen into remission. Hench inferred that the body must, the effect of jaundice must have been to compel the body to produce some potent anti-inflammatory compound, which, together with this man, Edward Kendall, he spent the next 20 years investigating what it might be, and turned out, as we will know subsequently, to be cortisone produced by the adrenal gland. His administration to the first patients with rheumatoid arthritis recorded in the following event. at a meeting in April 1949. The lights were turned down and a colour film began flickering on the screen. First came the before treatment pictures, in which patients with characteristically deformed joints struggled to take a few steps. Suddenly, an electrifying gasp swept through the audience as the single quote after treatment scenes appeared, and the doctors saw the very same patients drawn to the inclining steps, swinging their arms and legs, and even doing little jigs as if they had never been crippled at all. Even before the film ended, the watching physicians had filled the hall with wave after wave of resounding applause. Now, it turned out that cortisone was not a very effective treatment for rheumatoid arthritis because a high dose is required and unfortunately serious side effects. But it seemed logical that such a potent, to investigate the possibility of such a potent compound in the treatment of various other conditions. And indeed, over the subsequent 15 years, nearly 200 diseases were identified as being sensitive to steroid, which include large amounts of blood disorders, played a role in particularly connective tissue disorders, eye disorders, gut disorders, neurological disorders, skin disorders. The crucial point about the discovery, of course, is that it permitted doctors to, as it were, pulver to their ignorance about the nature and the cause of illness. And by the simple expedient of writing a prescription for cortisone, anticipating that patients would improve as a result. Cortisone as penicillin transformed practice. But their mode of action remains profoundly analyzed. They could never have been, as it were, synthesized from first principles. And it seems to me that they're best conceived of properly as gifts from nature, as Waxman suggested, too profound and too complex for us to understand what happened or even now. And they had two further benefits, two further consequences. And the first was to encourage doctors to believe that, to realize that it wasn't necessary really to understand nature in order to come up with an effective therapy. But rather that, as with penicillin and cortisone, the observation in the research clinic and the laboratory would, as it were, generate this cornucopia of new treatments without, as I suggest, the need for a profound understanding of the nature of life. And over the next 40 years, witnessed this cornucopia of drugs. We know about this in a way, but once you put it down on a slide like this, one begins to get the sense of the extraordinary nature of that achievement. And here we have 1940, 1950, 60, 70, and here we have the major categories of disease: infectious disease, cancer, psychiatry, rheumatology, circulatory disorders. And in each of these was a vast collection of enormous number of drugs were discovered during this period and by that time. A man called Paul Beeson, who many of you will have known, editor of the classic textbook Cecil's Textbook of Medicine, subsequently commented, in going through the first edition, that was in 1927, I one cannot fail to be impressed by the paucity of available drugs. Many medicines have simply disappeared: strychnine, arsenical, tincture of capsicum. Only about 30 drugs mentioned in the first edition are still in use today. By the time it came to editing the 14th edition, in the mid-1960s, he was able to identify 86 anti-infective agents, 5 antihistamines, 10 synthetic steroids, 35 other hormone preparations. The second aspect of consequence to be of penicillin and cortisone, was to encourage a sort of an optimistic belief amongst doctors that even the most intractable of illnesses might be curable, and sustained them in that belief through many years of vicissitude and disappointment. And the 25-year protracted research in search of a cure for childhood cancer, acute lymphocytic leukemia, exemplifies this point. And it all starts with this man, familiar to you, is Professor Sidney Farmer, Professor of Pathology at Harvard University, who in 1946 made the observation that an antagonist of folate antagonist produced a temporary remission in children. The universally fatal acute lymphocytic leukemia. Subsequently it emerged that Philip Hench's cortisone was also an effective and was also useful in inducing remission in these children, as indeed one of those fortuitously discovered antibiotics, actinomycin C. And then in a chance observation, the leaves of the periwinkle plants diverged had a therapeutic effect against these malignant cells, these malignant white cells, and resulting in the discovery of vincristine. Each of these drugs produced it, could only produce a temporary remission. And so it was suggested that perhaps they should be given in combination. It is impossible to convey the physical and psychological trauma this regime imposed on the young patients and their parents. Each dose of treatment was followed by nausea and vomiting of such severity that many children were unable to eat and became malnourished and stopped growing and ceased to put on weight. Then there were the side effects caused by the action of the drugs, which not only poisoned the leukemic cells, but also the healthy tissues of the body. The child's hair fell out, their mouths were filled with painful ulcers, they developed chronic diarrhea and cystitis. It's not for nothing that chemo has been described as bottle death. It's extraordinary to think that doctors persist with this entirely toxic treatment, despite only first producing a temporary remission in this illness, in acute lymphocytic leukemia. But they did persist. And that, combined with the introduction of maintenance therapy, resulted in this first cures which improved the survival rate in children from 0.1% in the 1954 cohort to 40% in 1974, and now, as we all know, it's somewhere up here. It seems to me to be an extraordinary state of mind. I think it reflects the extraordinary optimism that doctors could have persisted with this treatment for all these years in anticipation that ultimately it would I now like to very briefly talk about, as it were, the second pillar of this golden age of medicine, which was in a sense almost antithetical to this fortuitous discovery of drugs. And that was the devising of technical, empirical solutions to certain well-defined problems. And they come in three major categories, which we're all familiar: the life-sustaining, intensive care unit, ventilators, dialysis, pacemakers, diagnostic, which already mentioned, CT scanners, PET scanners, cardiac catheterization, surgical, joint replacements, lens implants, the heart, lung machine, the pump, which I'm going to mention again in a minute, endoscopy, and so on. Unfortunately, I can't feel that in time prevents me to deal with anything other than just to outline some of the, or just to mention some of the personalities involved. And so here we have John and Mary Gribben with the prototype of the open of the heart-lung machine, which would permit a familiar face, John Kirkland, a great star of the city, of course, and Walter Lillihigh of Minnesota, over a period of 10 years to perform the full range of open heart operations, repairing congenital defects in children, replacing diseased valves, and so on. And then we have here Joseph Murray in the background here, performed the first successful kidney transplant on the Herrick twins, Richard and Robert. I'm not quite sure which one is which, because of course they're identical. The operation was performed on the 23rd of December 1954. The kidney functioned immediately. Sir Joseph Murray was there in the background, subsequently report. Richard Herrick's recovery was rapid and complete, exceeding our highest hopes. Within a couple of weeks, he was well enough to be discharged from hospital, and promptly married a nurse who had looked after him in the recovery room after his operation. And somebody more, Patrick Steptoe, Robert Edwards, whose 12-year-long research program resulted in the culmination of the first test tube baby, Louise Joy Brown, in 1979, the first of tens of thousands who subsequently benefited from the process of in vitro fertilization. There is so much. The most significant influence, I think, from this incredibly schematic outline of this early age of medicine is how, in a way, it contradicts the common perception of medicine as being on a continuous onward and upward curve of progress, driven by a profounder and ever profounder understanding of the nature of disease. On the contrary, as we have seen, many of these important insights were essentially fortuitous, and the chance discoveries, and or in relation to these technical discoveries, the empirical solutions to well-defined problems. Science, of course, was important, played a vital role, a vital instrumental role. But it seemed to me that the main impetus behind the rise of medicine was primarily a moral one, and that it lay in the moral human qualities of determination, moral courage, sharp observation, imaginative thinking that made possible this most extraordinary evil. And then, sometime in the late 70s and early 80s, it began to seem as if this glorious period was coming to an end. The journal Nature commented on what it described as the dearth of new drugs, this precipitous decline in the early 70s, and the number of new drugs which were coming to market. The following year, Colin Dollery, who is a professor of pharmacology at the Royal Postgraduate Medical School, chose as the title of the prestigious lecture, The End of the Age of Optimism. And this is what he said. Problems seem larger and solutions to them more elusive. The morality and cost-effectiveness of scientific medicine has been challenged. Many people, including some of the most senior of the medical research hierarchy, are pessimistic about the claims of future advance. The age of optimism has ended. And then the following, James Fingarden, who's president of the American Association of Physicians, chose as the title of his presidential lecture the clinical investigator as an endangered species. And this is what he said. there has, he observed, been a declining interest in medical research amongst medical students and young doctors for several years, clearly visible to the heads of professorial departments, who increasingly find their recruitment pool gets smaller each year. Now, there might be several reasons for this change in tenor in the medical enterprise. But what it certainly did do was that it created a sort of intellectual vacuum that will be filled by two what will become very influential disciplines over the next 20 years, but which not up to this time had not played a terribly important role in the rise of medicine, and they were epidemiology and genetics. And I will deal with these. The first what I call the contribution of epidemiology, is the social theory. The notion that many common illnesses are simply due to the way in which we live our lives or what we have for breakfast, and that they are therefore readily preventable. And the second is the new genetics, which arose from a whole series of really important technical developments in the late 70s, which allowed geneticists for the first time to identify the genetic cause of disease. And I will deal with each of them in turn. So we start with the social theory. And there is, of course, no doubt that people who smoke and drink too much and have an unhealthy diet and don't take enough exercise will live shorter lives than others. But the point about the social theory and epidemiologists' claims was in the 70s and in the 80s and onwards was much more ambitious than that. It went further to claim that there were specific aspects of people's diets, whether particularly the high-fat diet, familiar in the Western world, that was specifically responsible for heart disease. And here we have a humorous outline of this. Here we have the Japanese down here with a very low rate of coronary heart disease, and the unfortunately overeating American colleague who, as a consequence of his overindulgence, has this much higher rate of coronary heart disease. So we're all familiar with that. And then in the simultaneously, these two very important epidemiologists, Richard Dole and Richard Peter from Oxford University, in a famous profile, in a famous monogram, The Cause of Cancer, claimed that 70% of the cancers in the stomach were due essentially to the Western diet. 70% of non-smoking related to cancers. Simultaneously, there were a whole series of epidemiological observational visualizations suggested by the estimating number of studies from the Nurses' Health Study, which identified virtually the full range of everybody's full range of people's lives in some potentially lethal disease or other. So alcohol incriminated in breast cancer, eating too much meat with colon cancer, and drinking coffee with cancer of the pancreas, and so on and so on. And even the inanimate objects, electricity pylons and mobile phones were incriminated in some disease or other. Well, of course, it's impossible to evaluate the validity or otherwise of these extraordinarily ambitious claims, which were predicated on the notion that essentially the practice of medicine was irrelevant. All we had to do was get everybody to change their lifestyle, avoid all these, terrible things going on around, and somehow they would live forever. It is, however, possible to sorry, I must just mention this is, as it were, summarizing this anxiety mongering, which was so prevalent, such a prevalent feature of the social theory. And here we have exercise factors, stress, red wine, according to a report recently, it can cause heart disease, hypothermia, feeling well-being, depression, in two-income families, arthritis sufferers, rats, and overweight smokers. So one can get the picture. Now, as I say, it's very difficult to evaluate the significance or otherwise of any of these claims, but I think it's important to note, interesting to note, that the most influential, the notion that somehow or other the epidemic of heart disease was a direct consequence of people's unhealthy lifestyles, was evaluated presupposes that there should be some sort of correlation, at least, between the changing pattern of heart disease and the changing patterns of food consumption over a period of 40 or 50 years. And here we have the pattern of heart disease in the United States, Australia, New Zealand, Canada. Here we have 1915. This stretches back to the 1930s and then peaks in the 1960s and falls equally precipitously. And this has now fallen down to these graphs have now fallen down somewhere around this area. And we see there's absolutely no correlation with the changing pattern of consumption, which is not to say that diet might not be important in one way or another. It's perhaps a bad idea to have too high a cholesterol. But the essential point was that the extraordinarily ambitious claims made on behalf of the wickedness of harm caused by people's patterns of food consumption was appropriate and unsustainable. And now to deal finally, very briefly, with the new genetics, predicated as I have mentioned, on this extraordinary series of the very important technical developments in the 60s, which allowed geneticists to chop up the strands of DNA into small bits and then produce lots of copies of them and then sequence them, culminating in the extraordinary gene, spelling out all the genes in the human genome in 2000. Genetics research will, like a mechanical army, systematically destroy ignorance. Promises unprecedented opportunities for science and medicine. We are familiar with this rhetoric, extraordinary claims made on behalf of the new genetics and the idea that by understanding illness at this really profound genetic level, that this as well will take us to the new, as it were, open up whole new avenues of treatment. Well, as we know, it hasn't really come out. Indeed, the contribution of genetics and to the Human Genome Project to clinical practice is virtually non-existent. Certainly makes very little, has no impact on ordinary, everyday family practice. I just want to summarize very briefly three aspects of that, and the first is the biotechnology and the contribution of the new genetics to the development of new drugs. And here we have a classic example, the insertion of a gene into a bacterium in order to produce prodigious quantities of some desirable human hormone like such as insulin. And although certainly it's being technically incredibly ingenious, it must be said that this contribution of biotechnology to new drugs has been a fraction of that achieved by the pharmaceutical industry and researchers in the 40s and 50s. And indeed, as the head of Genentech once famously observed, biotechnology has been the biggest money-losing industry in the history of mankind. And the second possibility, much vaunted possibility of the genetics, was this idea that you might be able to prevent genetic diseases by antenatal screening and selective termination of aborted fetuses. Here we have one of the many missing mutations responsible for cystic fibrosis. And here again, regrettably, the logistics involved proved to be much more difficult than anybody could have imagined. And it's interesting that cystic fibrosis, and we've known the genetic defect responsible for cystic fibrosis since 1989, that's almost 25 years. And there still isn't, despite the claims for it, a screening program for it. And then the third is gene therapy, this simplistic notion that one might somehow or other be able to remove the defective gene, a bit like blending a car engine and putting a correct one in this child with a rare genetic autoimmune disease. And the trouble with gene therapy, as we all know, is that unfortunately it just doesn't work. That's like more biology. So that, in a nutshell, in a very brief nutshell, is the rise and fall of modern medicine. And it's reasonable to ask why it is that the recent past, particularly epidemiology and social theory and eugenetics, have proved to be so disappointing. And I think this takes us to the central, unanswered, unresolved question, which lies at the heart of the medical enterprise, and becomes apparent when, as it were, one reviews the overall achievement of the last 60 years. And that has essentially been to drive or to push the burden of illness to the extremes of life. As medicine, at one extreme, has reduced infant mortality to its irreducible minimum of around 6 per thousand. Children die from prematurity or genetic disease. And then at the other extreme, medicine has pushed the burden of disease to the other extreme of life, where most people now are privileged to live out their natural lifespan. They're vulnerable, of course, to the chronic diseases associated with aging, which medicine can palliate, but cannot cure. And they include the circulatory disorders like stroke and heart disease and cancer, because cancer is primarily an age-determined disorder. They include arthritis and cataracts and dementia. The medicine can do something about it, but it cannot resolve. And the point about seeing medicine having, as it were, driven the burden of illness to these extremes of life is it brings into focus with extraordinary clarity the unifying principle of what it is that we don't know. And that is that all the illnesses which are not age-determined, which can occur at any time of life, that's multiple sclerosis and rheumatoid arthritis and diabetes and all the skin disorders like psoriasis and all neurological disorders and so on. The unifying principle about them all is that we do not know their cause. There must be a cause. There must be a reason why somebody gets multiple sclerosis or somebody gets rheumatoid arthritis, but we don't know what it is. And it's certainly not genetic, although of course there might be a genetic element, but these are not genetically determined diseases. And they're certainly not environmental or social, because there's absolutely no difference between the dietary pattern somebody who gets multiple sclerosis and somebody who doesn't. And here it seems to be the experience of this man is most instructive. This is Barry Marshall, at the age of 27, while working as a researcher at the Royal Perth Hospital in Western Australia, identified these organisms, Helicobacter, as the cause of gastric ulcers. And the effect of realizing, of recognizing that peptic ulcers and gastritis is primarily an infectious disease, and treating it accordingly has the most unbelievably profound effect on the illness. So if you treat it with antibiotics, your remission rate is virtually probability of remaining in remission, the probability of remaining in remission is probably 100%. If you don't give them antibiotics, the likelihood of recurring is almost 100%. Now, if one tries to imagine what difference it would make if we could understand the nature and cause of illnesses like multiple sclerosis or rheumatoid arthritis or diabetes in the same way that we now understand the cause of peptic ulcer, then one could anticipate at some time in the future a further golden age of medicine where one could, as it were, diagnose and treat these illnesses, and there's no reason why they shouldn't be treated just as effectively as we can treat peptic ulcer. So with that, on that quasi